you, Naja. I'm very happy to be here. And you, Federico, you said very nice words, exaggerate, but I think that is what you are doing is very important. I'm very happy to be here. And you, Federico, you said very words that exaggerate. Sorry, I have a feedback, an echo on what I'm saying.
No, it's just technical problem of.
Okay. No, I want to thank Federico for this invitation, because I think that what he is doing is really important for resident education and for training all the young neurosurgeons in all over the world. So I think that I really enjoyed this, and I'm very happy to participate to his job. So I'm trying to share my screen. If you see it, let me know if you can see it.
Nice.
You see it?
Yes, yes.
Okay. So he asked me to say a few words on intracranial aneurysm surgery, which is one of the so-called tough surgical field especially for young neurosurgeons. They have the occasion to see and to deal with an aneurysm late in their residency and their formation. So dealing with an aneurysm is always scary for a young and inexpert neurosurgeon. So having the possibility to train on something that is very similar is, I think, a very important chance. So the request I had is to show some surgical tips and some neurosurgical problems we can have during that kind of surgery and how to manage an aneurysm. Nowadays, managing aneurysm, especially at least in in Italy or in the so-called Occidental world, mainly regards complex aneurysm, very large and very difficult aneurysm, when also for endovascular. But from a surgical point of view, in a simple surgery, MCA aneurysm are the main topic we operate nowadays. Most of the more deep aneurysm are treated by endovascular. To a neurosurgeon, we do also very large aneurysm bypasses and very complex situation, but a classical simple aneurysm mainly is on the MCA. So we can start. This is from the beginning. It's very important, the position. There are several books explain the position. Of course, you need to have the patient very stable, so you need to have a fixed head fixation, and the head has to be rotated a little bit to reach the MCA. And this is different if you are looking to a communicating artery aneurysm or a PCOM. You can shift a little bit from 60 to 30 degrees. One of the main problems for a resident is to deal with the arachnoid. Arachnoid is, as stated by as pointed out by Yazagil, is a very important thing you have to deal with. Cisterns are our corridors. You have to move in the cisterns, and so knowing something about them and about the anatomy is important, and especially is important in this kind of surgery where all the aneurysma mostly are located. So all the Willis circle is within the arachnoid and within the cistern. So dealing with them is very important, and trying to dissect the arachnoid is important. Starting with an aneurysm, the first thing you have to do is opening the sylvian fissure, and you can do it with microscisor, but also with the pincette. Two pincettes are very useful to dissect it very gently and very smooth, trying to spare all the veins and the vessel coming out, especially when the patient is a little older. Preserving the sylvian fissure vein and the sylvian veins is extremely important. So try to pay attention also on the vein rather than the vessel, than the artery. This is a beautiful picture from the 7 Aneurysm book from Lawton, and which is full of beautiful pictures. And also here, it's important to try to keep the vein, and the vein always goes to the temporal bone. So you have to try to spare the main, or they can be more than one, but they have to keep it on the temporal lobe to reach the sylvian fissure. You can split them with forceps, small little forceps, and together with microscissors, like this is a short video. You can open it, and then with a small little jewelry forceps, you can split it gently and try to understand what you have behind and the vessel, and preserve all the vessel behind. This is the first step. You have to deal with opening the sylvian fissure to reach an aneurysm in the MCA. But this is also the first step also for all the aneurysm, because as you know, going through the sylvian fissure, you will reach all the other, all the Willis circle. And so you can go with the forceps, and then with a small scissor, identifying all the vessels. The vessel, you will see that all the vessels are going either on the temporal lobe, either on the frontal lobe, and if you dissect them smoothly, you can divide them, one on one lobe and one on the other. And often one of the problem you have is that you go subpial under the, you can miss the correct plane, and the risk is going on the subpial, leaving especially the arterial vessel on the wrong plane. And so when you realize that some vessels are not going on during your dissection, you cannot leave one on the on the temporal and one on the frontal lobe. Probably you have missed the right plane between the two arachnoids, but you are under the pial surface. And this is important to keep in mind. Then we all now are moving, we move to a retractor-less surgery. Once retractors were one of the main instrument for the neurosurgeon, now retractor-less surgery is something we can do almost everything without using the retractors. because we learned that they are harmful for the brain. So retracting the sylvian fissure with the sucker is much less invasive and much less harmful for the brain. And then, so you can keep the sucker on the non-dominant hand. Sorry, here is a mistake. Here there is a mistake. And then keep a dissecting instrument on the dominant hand. Then it's very important to gently dissect with a smooth dissector, expose the neck. You have to reach the aneurysm and then expose the neck. And in most of the cases, it's not necessary to expose the dome. The dome is the more fragile and the more dangerous part of the aneurysm. So it's not necessary to expose the dome. You just need to understand where the two vessels, maybe more vessels coming out from the bifurcation where the aneurysm is implanted. You just to understand where they are and how you can find a way between the aneurysm and the two vessels, and that's it. So don't expose the next the dome that often is embedded in the brain. So leave it there. And so this is another picture from Lawton that's splitting the sylvian fissure. You can reach the aneurysm following the MCA branches and then reach the aneurysm. And then once you have reached it, like in this case, you see we do not expose the dome, but just expose the vessel coming out and exploring the passage between the aneurysm and the vessel. This is, you can see here, one on one side and then on the other side. And often, more often than before, now we are using a temporary clip. So it's very important to have a proximal control on the MCA. So having the exposure of the MCA proximally is very important, and of course distal control, especially when you are dealing with the more complex aneurysm, is very important, because if you cannot treat the aneurysm, you need to decompress, but this is something that you will do on very complex and large aneurysm. So proximal control is always important. This means is you have to reach the MCA either from this proximally to the aneurysm, either from proximal, so coming from the the carotid, or also coming distally from the MCA when the aneurysm is looking front toward the frontal part of the sylvian fissure. But the more important, the first step is try to reach the MCA, and then having control on this, and then you can manage the aneurysm. As I told you, now temporary clipping is proved to be safe in most of the cases, and it's much safer to have a temporary clip if you can handle the aneurysm in a short time. It's very difficult that the temporary clip can give a problem. In 5 minutes, you can, once you have exposed the neck, then in 5 minutes you can apply a clip, so there are no risks to leaving a temporary clip for a short time. And then when you put the permanent clip on the aneurysm is, when you have a bifurcation, my suggestion is to put the clip on the perpendicular to the neck and not parallel to the neck, because it's very much more easy to put the clip and much more effective in closing the aneurysm when you put it perpendicular and not on the parallel to the aneurysm neck. You have to pay extreme attention on the perforating branches. They are often hidden by the aneurysm. They can be below the aneurysm, and so you have to look for them. And when you have applied the clip, it's very important to look for them and check if they are still open. This is an example of the aneurysm you already see. You already saw. This is the aneurysm. This is on a bifurcation. You have to dissect it, and this is the one you already saw in the. This is putting a clip, a temporary clip on an MCA, and then final dissection on the neck to check if there is a way of going through the hole between the neck and the M2 vessels. Here it is, and then you can apply the clip. This is something you can experiment also on the simulator, the UpsurgeOn simulator. You can see here that you can try to dissect gently and try to put to explore the neck of the aneurysm also in this model. That is in the touch feeling and the anatomy is extraordinary in this model from Federico, and I think that this is a way of trying to manage an aneurysm and try to learn how to move around an aneurysm in a gently fashion, and these models from UpsurgeOn are really great for that. Then when you have exposed the clip, exposed the aneurysm, you have to choose the right clip. There are several of them. There are several models and also several curve, and they are shaped for a wide variety of aneurysm. So you have, once you are there, and I don't think it's important to define it before, because only when you are there and you can see the anatomy is important to understand how and you can move around and how you can apply a clip. So defining it before, in my opinion, is useless. It's very important to understand when you are there what to do. And then you have to release the clip very slowly and very gently. And this is very important. Once, I remember that once the goal is to apply the clip, so put there the clip and then run away. This is not the correct way of doing, especially if you have done, if you have a temporary clip, you have the time and to apply the clip perfectly, so you can put, maybe you can move it again and try to release and put the clip slowly and gently until you are fine on and you think the positioning is perfect. And with the temporary clip, this is done much better. And then once you have applied the clip, it's important to check for the tip of the two branches of the clip to see if they are all behind the reach, if you have taken all the neck with the two branches. and this is still the same aneurysm. As you see, once you are there, you can put the right clip, which has to be chosen once you are there, and with the temporary clip, the pressure within the aneurysm is reduced, so you can manage it much better. And as you see here, you have to release the clip very gently without urgent movement. And also here, this is on the simulator, and you can see here that applying the clip, you can try release it gently, see that maybe is not in the perfect position, and then you can help yourself with the aspirator, trying to completely clip the neck without leaving a dog ear or something like that. Then when after post clipping, you have to check if the two branches are open, if the aneurysm is closed. So we have microdoppler and especially ICG video angiography, and where you have to check for perforator behind the aneurysm. Now, also in a very simple aneurysm or unrotted aneurysm, we use neurophysiological monitoring, which is essential because if you did some mistake, if there is a perforator cut taken within the clip, there is you can understand that there is a problem immediately, and not when the patient is already awakened, and so when it is too late. And so then you can move and reposition your clip. And then, of course, you have at the end of surgery to check with a postoperative imaging. It can be a CT scan or an angiography. This is an example of post clipping and intraoperative and ICG, and you can see that all the vessels are open, and the aneurysm is excluded. And then you can check it with this is a postoperative CT scan. I want to show you a rupture. A rupture is one of the most scaring things that a young neurosurgeon will experience, and will happen to everybody when you will do that or deal with the aneurysm. And so you have to be prepared. You have to be to keep calm and try to handle the situation. And I want to show you a video that also with a very small craniotomy, you can handle it. And this is an example. This is the aneurysm. You can see here a small, easy, classical MCA aneurysm. We did a small left pterional access. This was the access. You see it is a very small one that now is something. It's enough to open a Sylvian fissure and to reach an MCA aneurysm, and this allows you to discharge the patient if everything goes fine 2 days after surgery, and with a very little scare and very scar and a very minimally invasive surgery. And this is here opening the Sylvian fissure, as I showed you before, and here is the, wait, sorry. Here is exposing the aneurysm and checking the neck. You can see here, this is the neck, this is the dome. You can see here and you see here that we had a control of the M1. Let me stop this video. Wait a minute. If you can see here that the M1 is you have the control of M1 distally, coming from distally, because this aneurysm was directed toward in frontward, so it will cover the M1 if you come from proximally. And wait a minute, still is going on. I want to show you here. You see here, you can wait. Sorry. You see here that you can have a control on both the M2 segments and also M1 from distally. So here you have to see M1. And here is I am applying the clip, and you can see I apply the clip, and this is I released the clip. As you see, you have to have very smooth movement and check everything, but after releasing the clip, I want to show you that there was a problem. No, not this one. You see that the clip was not properly positioned because part of the aneurysm was outside. So I had to remove the clip, and here something happened. The clip slipped out from the plier and went directly in the aneurysm. And so this is something very dramatic. From now, the video is in real time. Fortunately, you don't have the audio of this video because you can imagine how is the audio, and it cannot be very nice to hear. But if you have, you have to have a strong aspirator, and aspirating, you can try to understand what happened, and then put the clip in and try to remember how was the aneurysm. You have to put the clip to control the bleeding, and remember that this is in real time. Sucking directly on the dome of the aneurysm, you can control and try to see again something and understand how the anatomy is, and then you need to put a clip to control the bleeding, and this is how the clip was positioned, and then finally the bleeding stopped. Of course, this clip was not in the right position, and as you see here, this clip slipped from before, and of course here is not correct because this clip was applied just to control something, and as you see here, the two M2 branches are closed, so you have to reposition it, and then you can control and finally control the bleeding and securing the aneurysm. And this is so also from a very small exposure like this, and as you see here, without retractor, you can handle intraoperative rupture once you keep calm and and know what to do. This is the final ICG with the aneurysm excluded, and the two branches are open there. And what happened in this time, in this situation, the applier, the patient awoke without deficient, and she was discharged in day 3 from surgery. What happened in this, and what I've learned from this experience was that the applier wasn't inserted correctly into the clip. When I removed the clip and I want to change it and put a straight one because this was too curved, you can see here that the applier was not perfectly positioned in the clip, and this was the reason why the clip slipped from the applier. So this is the end. I want to show, I hope that you could take some message from this exposition. You have to keep calm, you have to move smoothly, you have to control the proximal vessels, and also if in the aneurysm rupture, you have to learn how to control the situation without panic. Thank you, and I hope if you have any question, I'm here.
Thank you so much, Professor Senzato, for this brilliant talk. Do you hear me? Yes.
Yes.
So we still have second talk about aneurysm surgery and peritoneal, which will be made by Professor Fadi Charbel. So what do you prefer? Do you prefer have question now or by the end of the second talk?
I will listen. Very happy. I'm very happy to listen, Fadi Charbel.
Okay. So
okay, because we have some comment and some questions for you, but of course we don't want to bother you if you have.
No, I'm here. I have time.
Okay. Thank you so much.
Thank you. So the next talk is the talk of the well-known Professor Fadi Charbel from Illinois, University of Illinois at Chicago. He's a neurosurgeon and inventor of many devices and simulators in neurosurgery. So in 1 minute, we will start his talk. Unfortunately, he couldn't be with us. He is at this time, it's 4 o'clock where he's living.
No, but he had
and he's far from technology, so he can't be with us. So let's start the presentation. Sorry. Sorry for this technical difficulty. I'm trying to share the presentation of Professor Charbel with his audio. So, no. Audio, I don't know why. Oui, madame, c'est bon.
Je peux poser des questions, c'est bon.
Oui, madame. أنا بس واحد دقيقة باش نبارطاجي باسكو
Try to press the speaker icon here.
Sorry, we have.
Training project using a state-of-the-art training facilities in Morocco and great technology to help the future training in psychomotor skills. It's always a great pleasure for me to participate in joint endeavors led by Professor Najia El Abadi, my dear friend. Dr. El Abadi is the course director and head of the Department of Neurosurgery at Sheikh Zayed International University in Rabat, a beautiful city and a beautiful country. In addition, Dr. El Abadi is, of course, the world leader of international in this important task. Hassani.
It used to work.
Do you hear all the
yeah. Now in a few minutes ago, it was working. No, not.
Endeavors
now, yes,
with my esteemed colleagues from Morocco, led by Professor Najia El Abadi, my dear friend. Dr. El Abadi is the course director of the Department of Neurosurgery at Sheikh Zayed International University, a beautiful city and a beautiful country. In addition, Dr. El Abadi is, of course, the world leader of international neurosurgery. She is assisted in this important task by the wonderful Dr. Fat Derkawi. Here are my disclosures related to the transonic flow probe for flow measurements in neurovascular surgery. So let's start with the goals of aneurysm surgery. Whenever we treat aneurysms, what are we trying to achieve? And we can do that either directly coils or indirectly with flow dissection, and often also sometimes in the parent vessel. Now, what happens? Catastrophic consequences. It involves major vessels such as the carotid, the MCA trunk, or an anterior communicating artery, but also perforators, whether it's the basilar perforator, the choroidal perforators, the M1 perforators, or never to forget the anterior communicating artery perforators, which, if compromised, may not give an obvious neurological deficit, but will certainly compromise the cognitive function of the individual, which is perhaps even more important. The vessels can be compromised indirectly. This is something that we do not see at surgery and will not be detected unless we measure flow. That can be from atherosclerosis, from a kinking of a clip, and I'll get to some examples to that. Thrombosis is a big problem, and we have to be careful about that. And there are adverse hemodynamic consequences that can occur, especially in the endovascular treatments. So how do we assess vascular integrity? At surgery, we can look at the vessels with visual inspections.
Please go to the next slide.
Topical imaging with either digital subtracted angiography or video angiography with ICG. And however, some of these measures are lacking physiological
You can't follow?
input.
We
Excuse me.
don't see the other slides.
So vessel
Okay.
flow
The
is
local
quite
factor.
important, as you know.
Okay.
Uh,
Now?
So we do measure flow,
No.
and it's not
No. Okay.
12.
We can hear the Fadi talking, but the slides are always fixed. In the meanwhile, you would like to address some questions to the speech I did before?
Okay.
Vous inquiétez pas.
We do measure flow, and it's not velocity, it's actual flow. And the advantages are that we can get immediate feedback on the status of the vessel, and we can repeat the measurements. And that has been very helpful to us and many of you. In 12 steps of aneurysm surgery. Here they are. And these are important because each one of these has to be taken into consideration and has to become part of the thinking process of every aneurysm surgeon. The scalp incision and the craniotomy, we'll go over that. The very first thing after that, and at any given time, the first thought in the mind of the surgeon should be proximal control, proximal control, proximal control, proximal control. How am I going to achieve proximal control? Right after that, it has to be, where is the neck? And everyone is thinking about all of this. It'll be important to get a clip ready, and we'll continue to the next steps. So let's start with the scalp.
You have to move to the next slide.
They're related to that. But nowadays, of course,
you have to move to the next slide because there's still on the vessel flow analysis.
And endovascular. So we have to be minimal, meaning minimal shaving, if any, a small incision, and little tractation. This is the standard craniotomy for all anterior circulation aneurysm.
You have to move to the next slide manually, probably.
I don't have this option because it's registered on PowerPoint.
Retraction on the muscle. Cut the muscle. The incision is usually 1.5 inches by 1 inch.
Does it work?
Dimensions.
Now it works.
A variation is to undercut the muscle rather than and elevate it, rather than incise it. Less pain. The burr hole is placed under the muscle, a single burr, and that's the completion. Going to be repositioned. What can we do with that? We can do pretty much everything in the anterior circulation. Here's a relatively uncomplicated aneurysm. We're starting with the splitting of the fissure, which has some blood in it, inflating the fissure, and we start to dissect. And remember, the first thing we're thinking about here is proximal control. That means we need to find the M1 in this small MCA, relatively small MCA aneurysm. Limited focused exposure of the fissure directly over where we think the aneurysm is, and we already see now the M1, the aneurysm, and one of the M2 branches coming out of it. The flow is being measured at the vessel at risk. We already have a point for proximal control if we need it. Here's the aneurysm. And it is important with all aneurysms to sharply dissect the dome. This is now step number 10. We're mobilizing the dome. Now, I don't have a temporary clip on, but I can easily place it. I've already trialed it. I have it ready. The patient is under burst suppression to allow safety of temporary clipping in case it is needed. Neurophysiological monitoring can be used sometimes. It depends if the aneurysm is complex. In this case, I was not using it, but there's nothing wrong with it. Now, the key maneuvers here with aneurysms, especially small ones, is to clear the neck from the arachnoidal adhesions. Absent that, when the clip is placed, it will pull the emerging vessels around the aneurysms into the clip and cause some narrowing, which would be an indirect narrowing, even though the clip is not on the vessel. So this is mobilization of the dome fully with release of every bit of arachnoid adhesion. And again, the aneurysm is secure because we can immediately place temporary clipping if needed. Now, if you feel comfortable placing the temporary clipping beforehand, but less time on the temporary clipping is obviously better for the patient. Now we have a good idea where the aneurysm is. I'm going to proceed with clipping of this aneurysm. After measurement of flow in the other M2 division coming out of it, we're trialing the clip with the right hand. The angle is not favorable. You'll see I'll use the left hand instead. So now the temporary clip goes on. Because especially in small aneurysms, it is important to deflate the aneurysm to allow for better placement. And notice what happens here. The clip is not shoved into the aneurysm. With my left hand, the clip is positioned around the aneurysm, and then this small aneurysm is pulled into the clip, which then allows the clip to rest gently and fully and encompass the whole origin of this aneurysm. Temporary clip is then removed. The flows are checked. You see it's a very focused fissure splitting, and that's how we do all these steps of the surgery. So this is one aneurysm. What else?
C'est l'anévrisme qui a éclaté. C'est l'anévrisme qui a éclaté.
Tu ne veux pas donner la parole à Louis? Parce que c'est désagréable quand même qu'ils aient les dents.
Ouais.
Et après, on passe à repasser avec lui. Termine la vidéo. D'accord?
Oui.
C'est désagréable pour eux et pour les gens.
Oui. I think we have a technical problem with presentation of Professor Fadi Charbel. Maybe we can have a question for Professor Senzato.
No.
Or we move.
Yes. I have a question.
Professor Marco?
Yeah, I'm here.
Yes, we have, I don't know if you have questions.
Hi, we are sorry for this inconvenience with this technical problem, but we can we can maybe fix it, and then we will project it after. But I have just a comment and a question for Professor Senzato. The first one is. The comment, it's I was in a webinar 1 month before with the Professor Christian Raftopoulos, and I think you know his strategy about the Sylvian aneurysms. Are you hearing me, Mark?
Here. Okay.
The strategy and the philosophy for aneurysm, Sylvian aneurysm, and he told us about the the anatomy is very important because in his opinion, the early branch temporal frontal branch, it's not usually we said that the maximum of the Sylvian aneurysms is in the first, and in his work he demonstrated that this the maximum of the aneurysm, rapid aneurysm, it's located in the early branch of frontal branch of the Sylvian, not in the first bifurcation. And this is why he is telling that this is why we sometimes confuse between the two types of this type of aneurysm. And the second thing, it's what do you think about bypass in some cases, of course, not always, but when we have some giant and complex aneurysms and more perforated go from the sac of aneurysm to do bypass before and try to of course the artery.
Yeah. Now, when you have a very large aneurysm, they are often thrombosed, and often you can have perforator coming out from the neck directly, and this is a case where you have to think about bypass. We have done several of them, and there are also some strategy we can do also. Not always you need to have an external bypass. In sometimes on an MCA large thrombose, that can you hear me?
Yes,
Yeah.
please.
We did also some side-to-side aneurysm, side-to-side bypass between the two branches of M2. And then you can exclude the aneurysm and one of the branches, leaving the other open. So bypass for sure is a very interesting technique that you have to apply all very often in very wide and large and thrombosed aneurysm. So if this was the question, bypass still is a very important technique that you need to handle when you have to deal with the very large MCA and bypasses. Then the aneurysm. You can, in most of the times, manage it with a superficial temporal artery, so you don't need to have a large long bypass with radial and beam bypass. Now it's very rare that we use an interposing vessel, but just with the two branches, one or two branches of the STA, it's very enough. It's enough to handle most of the MCA aneurysm. But I didn't understand exactly what was your question about the Raftopoulos topic, because you are saying that the aneurysm often is on the first division of the MCA. Is that correct? No, I cannot hear you. I can't hear you. No, you have the microphone off.
here.
Yeah.
He is in his philosophy. He is thinking that there is perforators. It's called early branches of temporal and frontal early branches before the first bifurcation, and he always try to, of course, looking for them before to go to the first bifurcation. And he said, yeah, and he said that in his theory that it's more than frequent to have this location, the aneurysm located in these early branches than the first bifurcation. And maybe I would like to ask you, in your daily practice, how many aneurysm you operate, and how many you give it you give it to the endovascular, because in our department we have some are not really we are not agree with our endovascular, because he always treating them by a coil, because he's one of the first of maybe the first or the second endovascular in Morocco, because we have only 3 or 4 endovascular in Morocco, and sometimes there is many neurosurgeons from our others country and others cities in Morocco send them directly to the to our I am trying to have a multidisciplinary staff to discuss with all the team, of course, the neuroradiologist, neurosurgeon, and the anesthesiologist, and but we don't succeed till now to have a lot of location of Sylvian aneurysm to operate. Please, thank you.
Also here, of course, you of course you know that now endovascular has taken a lot of room in the vascular surgery. I'm very lucky here, because probably you know Dr. Boccardi, who is our endovascular. We have a very good relation with him, and we really work in team. So most of the cases are discussed before addressing them to an endovascular or a surgical treatment. I think that in trying to keep for simple aneurysm, trying to keep the surgical set is something that, in my opinion, is something we have. It's a battle which is not have no future. I think in most of the simple cases, endovascular is a very good choice, and especially when they are in the deep, deeper than an MCA. We have done here in Italy, in Milano, almost 80% of the aneurysm, especially when they are ruptured, are treated by endovascular. And my experience now is more on unruptured aneurysm rather than ruptured. Ruptured are almost always 80% of them are treated by endovascular with the good results. So I don't agree with the battle saying surgery is better. It's just probably a very little better, but in overall the results are absolutely comparable. So I don't think we have to force surgery to keep it in the surgical field. On the other side, complex aneurysm, when they require some equilibrism or very complex endovascular procedure, sometimes I think that they don't need that. Surgery is much better than a very complex endovascular procedure that can be more risky than a surgery. But this is for complex aneurysm, very large, very complex, with several vessels involved when they are thrombosed. So we are lucky to discuss every case of very complex aneurysm, and many of them are treated by surgery. Often we are doing combined treatment for, especially for large aneurysm and thrombose. We can do the bypass, and then they put a flow diverter, or treat some of them by endovascular and do combined surgery. And I think that this is a good choice. Sometimes you have a less invasive treatment, so just doing a small bypass and then sending the patient to the endovascular can be a good choice also, without because when you have a very large aneurysm thrombosed, often you have perforator behind the brain surrounding the aneurysm is very fragile. So to reach the neck, sometimes you have to manage the brain. And so our part is to do the bypass and then do the complete the occlusion with endovascular can be a good choice also. But you need to, and I agree that we cannot try to keep all the aneurysm surgery to surgery, because all the aneurysm treatment to surgery, because this is something that we will lose. In that we have to work together with the endovascular people and try to have a very good relation with them, because coming from them, we will have a better solution for the patient.
Okay, Marco, thank you very much for your comment. And even for the Sylvian location, I'm not totally agree, because we had more problem with our endovascular, and it depends, of course, as you know very well, it depends on the location, the choice between, of course, endovascular and microsurgery. I'm totally agree with you when we are in the posterior circulation. We prefer mainly to use, of course, endovascular than microsurgery. So thank you so much to be with us, and really it's a very we have a good time. All the audience here, thank you for your excellent and brilliant of course talk, and I hope that you can continue with us after, maybe in this afternoon, with Federico, and I hope we can see you soon after this after the over of this pandemic situation, and stay safe. Thank you very much.
Thank you very much.
We have a problem.
Nice to see you.
Nice to see you too. Bye-bye. So
Bye-bye.
we will move to the Professor Borba. Are you here? Professor Borba?
Yes.
Luis.
Luis,
how are you?
I was watching the presentation.
Luis, I think we will move to your talk, because the talk of the video of Fadi is doesn't work in the same time with the Zoom and the audience here. So I am so sorry for you, but I can we can send it to you, because I know that you want to listen to him. If you want to, we can send it to you later.
Yes.
Later
Okay.
on. So I just let me allow me to introduce you. I know that I don't need to introduce you. You are very known, well known around the world. You know, I think when you give at least 2 or 3, sometimes more talks weeks, and your manner to give the talks, your passion, your passion for the neurosurgery, and especially for this subspecialty, which is skull-based neurosurgery. It's very, very amazing, fantastic, phenomenal. Thank you so much to be with us. I know that you are, of course, the vice president currently of the skull-based surgery, and you are from Brazil. I am just telling that for our young neurosurgeon. But you are working now in Russia. Is it right?
No, I'm working in Brazil.
But you come back to Brazil. Okay.
Often to Russia. Yeah.
Okay. So thank you so much again, and go ahead. You can.
Thank you, Professor Rajat. Thank you, Hassani. Thank you all. Can you hear me? Can you?
Yes, of course. Yes.
You can hear me. Okay. I was watching Professor Sensato presentation. Think, we do neurosurgery to clip aneurysm. It's so nice. It's the real neurosurgeon clipping the aneurysm. They dissect the vessels. I was in the presentation about aneurysm. I stopped to see and enjoy and really have a great time. I tried to share my screen. I don't know if you please see. You can you see my screen?
Yes. Thank you.
Okay. Neurosurgery every day is changing. Every neurosurgeon tried to put his name in their history. And always when we talk about neurosurgery, we talk about the results, new approach, new ideas. And with the time, the situation start to get some balance. And the balance that you get, that from the old roads, you can get many ways to reach something. You can go from the bottom to the up of Africa. You can go to the historic route in US, or the routes, the first European route in Greece. And the retrosigmoid approach to CP angle is one of the routes. When you talk about skull base, you talk about Petros's approach, current orbital zygomatic, transcondylar, trans something through the nose for everywhere. But we know that the 90% of the case of skull base lesions, you can remove by pteronal approach or retrosigmoid approach, independent of the size. The retrosigmoid approach is a direct route not only to the CP angle. You can go up, you can go down, you can go to the other side, depend of the pathology. But one thing that is very important when you talk about CP angle, you are like the elephant. We are like the elephant in the crystals. And this way, you need to learn to work in these windows between the 5 and the 7-8 complex, 7-8 complex and the lower cranial nerves. superior to the 5. Have the petrous vein that in the past we used to coagulate in the beginning. Now you know that you need to preserve. Veins you need to preserve. At least try. You never know what will happen if the vein in any part of the brain. See, it's important to tailor your approach. What changed and give you a lot of support in this skull base? The intraoperative monitoring. It makes us more conscious, more delicate, and give us information, not only during surgery, but from the prognosis of the case. If you do acoustic neuroma, if the facial nerve is okay in the end of the surgery, you can be happy that facial nerve will be okay, or have some slight deficit that will come back. If you lose the facial nerve, maybe you already know that you have problem in the post-op. And for this, you did a good machine, see, with no delay, a good team, a neurophysiologist that is involved in the treatment, not as our friend here that the surgeon was so quiet that he decided to sleep a little bit, but the machine was good. This teamwork is essential when you work in the skull base. Every neurosurgeon has his own preference about position. I know that a lot of people in Europe use sitting position. For CP angle is wonderful. See, for CP angle, sitting position is very good. You know why? The blood comes down and the field will be very clean, very clean. But for me, I don't have so long arm. I get some difficulties to stay long time like this. See, and to drill with use the drill with the arm in stand, sometimes long drilling, not so stable. I do surgery in stand position. I don't do surgery in sitting position myself. See, I move around, but I fix my hand the way I can move and be stable. I prefer to use this position. Some people just rotate the head. Some people use sitting position, as I said. Why I use this straight position? First, to don't twist the anatomy. I know completely the anatomy in the parallel view. See, I know where is the facial nerve, where is the trigeminal nerve. It's not to rotating the head. I see neurosurgeon doing CP angle, doing some kind of surgery, and he rotated the head, and the head become like this. It's very confused. And the anatomy will be confused also. I remember Professor Yashagil has done surgery always, or straight or third degrees. No more than this. And you have the anatomy in your hand. I remember the papers of Professor Roton was very difficult to understand because the position that he was putting the pictures was different the position that you used to see in surgery. Because this, when you study anatomy for surgery, try to put the picture in the position that you see in surgery. And the other advantage of this position here, we don't close the other side internal jugular vein. Right? You just rotate sometimes, you can close the vein. Now I'm doing I put in position and do ultrasound to see if the veins are open. It's very often, just twist a little bit, you can close or decrease the flow in the contralateral internal jugular vein. What's the problem with this position? The shoulder. See, for right-hand surgery like me, when you do right side surgery, the shoulder will be a problem. Well, how you fix this? You pull the shoulder anterior in the direction, down and anterior, and the shoulder will be out from the field. See, if the patient has short neck, see, he's fat, has a short neck, this will be a very difficult situation, maybe in this situation, you need a sitting position. When I start neurosurgery, we are doing craniectomy. The patient in the post-op had a lot of pain because the muscle was going directly to the dura, and the patient had pain in the post-op. We prefer now you do craniotomy. The way you do craniotomy, you do just one borehole over the asterion. That's the junction between the transverse sinus and the sigmoid sinus. We rotated with the craniotomy in this direction for the craniotomy. Okay, this right side, okay? And the mastoid, in this part, we prefer to use the burr, the drill, the cutting burr. See, here's the craniotomy, here's the cutting burr. You know why? It's more difficult to pass here, and you can damage the sigmoid sinus, or you can damage the posterior emissary mastoid vein. See, you can remove and have bleeding of the sigmoid sinus. This you can see here. This is the way you do the craniotomy from this part and the cutting burr from this part. And don't need to expose totally the sigmoid sinus. In some situation, maybe you need a little bit more, a little bit less, but we need this angle between the sigmoid sinus and transverse sinus. The fifth nerve will be in the angle. The 7 and 8 will be almost in the same level of the posterior emissary vein. You can go in this direction. Remember that you are working in the posterior fossa between the nerves. Remember that the arachnoid is to stay to the nerves. Remember that neurosurgery for vascular disease, you dissect the vessels. Neurosurgery for tumor, you dissect the arachnoid. You keep the arachnoid to the structure. And the trick is to use anatomical landmarks to find yourself. Have a large tumor in the CP angle. How I can find the nerves? You open there, it's only tumor. This way you need some tricks. Take CSF lake, find the 9th, find the 11th, find the 10th, and now you know where you are. How you find the 9th? The glossopharyngeal nerve, the choroid plexus. Find the choroid plexus, just underneath will be the 9th. Just up will be the facial nerve. And it's very important, this technique that they call the onion technique. What is the onion technique? The onion technique, you go inside the tumor and open the arachnoid around like an onion and leave this arachnoid around. You don't need to see perfectly and clearly, very clear the nerve. We need to know where is the nerve, keep the arachnoid, and keep this situation. The most common tumor in the CP angle that use the retrosigmoid approach is the vestibular schwannoma. The vestibular schwannoma, independent of the size, is the same technique. You can use middle fossa. Some ENT use to come from the middle fossa and open the internal auditory canal. You can do translab. There are a lot of ENT like it. That is nice technique. It's very nice technique. You can expose well, and you have the controls, the facial nerve, easier than you can get by the retrosig. But we, as a neurosurgeon, learn to do by retrosigmoid approach. What's the trick? First, you identify this tumor like this. You open the internal auditory meatus. Don't open a small hole, see? A large hole. Almost 180, see? 100. To expose the whole internal auditory meatus from the superior limit, from the inferior limit. Important to know in the pre-op CT or MRI, the size and the height of the jugular bulb. Because if you sometimes the jugular bulb is so high that just touching the internal auditory canal, you can have severe bleeding. Imagine a severe bleeding of the jugular bulb in sitting position. Man, it would be terrible. It would be air embolism, will be the whole thing will be inside the heart. See, the idea, you go there, decompress, and see the nerves. You can do this with a small tumor like this, patient with hearing preserved, with facial nerve preserved, intraoperative monitoring, open the canal, open the dura, identifying the nerves, and the intraoperative monitoring. Follow the guy. See, the guy that is in neurophysiology has to be with you all the time, tell you all the technique. Avoid maximum that you can coagulation. You never know how much the nerve will support. See that the vestibular nerve, the facial nerve will be down, the tumor will be in this part here. This sucker here should be a little bit smaller. The suction, I think, is too big. See, in this area. See, I do surgery, and after I watch my own surgery to see what I did wrong, what can do better. I see this video. See, this sucker is too big. Has to be a little bit smaller than this, and dissect in the direction of the nerve, not contralaterally. Dissecting like this, from anterior to posterior, and try to remove piece by piece, see, from the last step. How much you open the canal? I prefer to open widely. I never know where is the end. At the end, I prefer to put the endoscope and see if there is a small tumor. You see, I was thinking that I got to remove all the tumor like that. Okay, I remove everything. I put some water, irrigate. There was a small tumor that was there in the fundus. See, the irrigation, the endoscope, here to help you to see this anatomy and preserve totally the nerve and maybe the hearing. Hearing, you never know when you preserve in surgery. Maybe in the post-op, you can get this information. You do the same technique for large tumor. First step, take CSF, release the cerebellum, identify the nerves and the structure of the jugular lower cranial nerves. You can start from two ways. One, doing first the decompression and after open the internal auditory meatus, or you do a slight decompression and go to internal auditory meatus. I coagulate ducts in this posterior part after stimulate. I never saw, but there is a lot of report in the literature that say the facial nerve is behind. I never saw the facial nerve in this posterior part, but always I stimulate to see if there is something. To open the canal, you open the dura. Sometimes I leave this piece of dura. Sometimes now I'm cutting. I'm afraid to use this. One trick here: use cutting board. Don't need to use diamond board. I use the Midas drill and the striker drill, the true drills that I'm used to take it with a cutting board and large board, not small one, large. I need to make a wide open of this thing. I go faster here. You open this, we identify the tumor inside the canal. Sorry. After we start to do the decompression, the maximum that you can, decompress. I dissect a lot of people and coagulate just a little bit. Now you go do the onion technique. See, start to find these arachnoids and leave the arachnoid to the structure. Don't bring the arachnoid with the tumor. You can use the ultrasound, the ultrasonic aspirator. you can, you don't have ultrasonic aspirator, there's the suction. You give more time until you find this plane here. See, you see the arachnoid, you start to find the plane. When you find the plane, you know where will be the nerves. You just follow the anatomy of teeth. You continue in this dissection. I go to the end here, it will be a bit too long. I can send to the resident this presentation later that you can see the video step by step to see. Now is the most important part, the part that you try to use minimal coagulation, because the facial nerve will be there. Now, and separate the tumor from the nerve, not the nerve from the tumor. I know that the facial nerve will be in this layer. And if you ask me, which one is the facial nerve? I don't know. I don't know if the facial nerve is here. See, it's in this area here. This will go cleaning, dissecting. Now I can see the facial and continue from medial to lateral, not lateral to medial. See, in the middle part of the tumor, with the part the tumor will be more attached to the nerve. Always you can do like this? No, sometimes it's difficult. Sometimes it's difficult. But at least try to preserve the maximum. You see the facial will be like this. Here I can see well. Here I can see. I don't know where it is here. Inside the canal is protected by the stomach. This will preserve the facial nerve function. If you preserve the facial, you preserve the acoustic. But does not mean that you preserve the function and the hearing. Because the nerve, acoustic nerve, is very sensitive. It's very easy to lose the function. See, I do the surgery for this tumor to remove the tumor, to save the life of the patient, and to save the facial nerve. Maybe, if I can preserve the hearing. I know that now in the world, everybody preserves everything. In acoustic neuroma, I don't know, they show tumor like this, big like this, they preserve everything. I don't know. In my hand, I'm a humble man. I cannot preserve everything in every case. We have large tumor like this, cystic, looks easier. No, it's more difficult. Don't know. We have no idea where is the facial nerve in this situation. And sometimes you dissect the arachnoid, it looks like the nerve, it's not the nerve. This, the intraoperative monitoring, help you a lot. You do the surgery, you dissect the maximum that you can. Sometimes you leave a small, how to say, the arachnoid, see, that looks like capsule of the tumor, but in the CD post-op, you can get a nice removal. Another tumor in the CP angle that you can do surgery, that the retrosigmoid approach help you a lot. It's very important to understand the anatomy. It's very important to understand the symptoms of the patient. Talk of the patient before surgery and know the symptoms that the tumor, the finds in surgery has to be the same that you get in the intraoperative surgery. You see the case, epidermoid CP angle, same situation, open the cyster, take CSF leak. One trick that Professor Yashagil, I will say, your craniotomy must have a cistern in the field. A cistern, it means to take CSF, see, to release CSF. Plan your approach. Plan your craniotomy to have a cistern and go there, take CSF, release the brain. You can go the surgery in this epidermoid cyst. You can, the surgery is bloodless. See, you cannot bleed. If you bleed, you lose completely the anatomy. You miss the field. You go in cleaning in maximum that you can. Sometimes when the patient is very symptomatic in the pre-op, symptomatic, I talk about headache, severe, sometimes vomit, look like intracranial hypertension, is inflammatory reaction to the tumor. In this situation, the plan between the tumor and the nerve structure is not so easy. Okay? In this situation, maybe you need to leave a small piece of tumor attached to the brainstem, attached to the nerve structure, because the inflammatory reaction of the epidermoid tumor. But this lady, this young lady, has facial pain, terrible facial pain. We did the surgery, we removed, we cleaned the CP angle, or see, look like, oh, it's nice. See, arachnoid preserved, basilar artery, fifth nerve, seventh nerve, petrous vein. But this lady had what? He had trigeminal neuralgia. I need to see the whole length of the fifth nerve. And I put the endoscope. What the surprise here? In the trigeminal, in the porus trigeminalis, there was a small tumor that was going through the macroscope, through the porus trigeminalis to the middle fossa, if you see in the pre-op MRI. See, if I remove this tumor, use just the microscope, we couldn't see, you will not see this part, and the patient will wake up with the same symptoms. See, the technology is there to help you. The microscope, endoscope, the ultrasonic operator, the neuronavigation, everything. Pray a lot. You see, everything can help you in surgery to have removal. The technology has to be combined to get a better results. Sometimes we have cases like this, especially in epidermoid tumor. I think, oh, I cannot do by retro-sig. How I can do this this here? Okay, let's try. I prepare to do Petrosal approach, but in this situation, I try first retro-sig. If I need, I go more. I prepare the incision, I shave the head. See, let's start here. See, I put this pound, you see, maybe I can go anterior here. Maybe I can go. Let's try here. What you did, you came just for the posterior fossa, go to the end, you go there, and the tumor gave me the approach. The beauty of the epidermoid cyst, that the compression of the brainstem, the compression of the nerve structure is so slowly during long time that it remains in position. See, when you go and do the dissection and you follow the nerve, you follow the tumor, and the tumor is there, is going to the other side. The tumor gave me the approach, and I didn't need in this situation a more extensive approach as the posterior Petrosal approach. And the pre and the post-op, in the hospital, see, slight facial, maybe, see, and recover it. Who gave me the approach? The tumor. The tumor gave me the approach. Now it's come a different issue. The meningioma. The meningioma, the great majority of the time, a hard tumor. Very rare you can aspirate, but the majority of time you have to coagulate and cut. We need space. We need space. The trick of meningioma is to do underwater. Why underwater? Irrigation. Irrigation between the tumor and the arachnoid is trying to give you some plane. And you work like the Spider-Man, you see, between the arachnoids. You see, and the Spider-Man go there. And very important issue in meningioma that I want to say again, try to save the vein. At least try. You never know what's happening if the vein of the brain. This is one case. Retrosigmoid approach is directly. You go direct to the tumor, you cut the vascularization that's coming from the petrous area and remove this big mass. But what makes me a little bit not concerned, worried, I don't know word I want to say in my terrible broken English. When you go to American Congress, see, the AANS, American Association of Neurological Surgeons, the largest meeting in the world. When you go to the booth of gamma knife leg cell, And you see this picture, Lexel gamma plane. Look this meningioma here. Look the attachment of this tumor. Look the size of this tumor. Man, this tumor I can do in every part of the world. Don't need any skull-based center, something like that. Don't need like that. It's a straightforward surgery. Retro, supra, see, cerebellar approach. You cannot do this, my friends. Cannot do this. Cannot sell to our patient the thing that is not better to them. Let's do what's better for the patient. Like this young lady here asked to her father for iPad, and her father gave her an iPad. It's iPad, no? But it's not the way, what they want to see. And the tumor is like this. Look at this. Similar case. Very small attachment in the tentorium. See, you go there, identify the tentorium, cut the vascularization of the tumor. See, it's game over. You can remove a little bit more tentorium to avoid any kind of recurrence. See, you can get this. You see that. And the small ball that is in the posterior fossa. Very easy plane of the cerebellum. And in the end, it will come like this. Very simple procedure. Retro supracerebellar approach. It takes a step, the cerebellum go down. In this case, I did in sitting position, okay? The cerebellum was coming down, see? And you go slowly, and take the ball out. And this patient is cured without any need of radiation, any need of adjuvant treatment, see? Up to now, the best treatment for meningioma is the radical total removal. Does not mean that you can get in every case. I'm not saying that you can get radical removal in every case, that you need to do radical removal in every case. But case like this, don't send to radiation. Send to the OR and take home. The pre and post-op removal and preservation function. Now you have more complex case. I say, oh my God, this I need Petroso approach. I need to understand temporal bone. But look at this. What's the angle here? Retrosig directly here. Petroso like this. Maybe you can get easier for a Petroso here, but you have the root. The highway that the retrosigmoid approach you give in this situation. But the most important thing in this situation, the tumor is totally in the posterior fossa. There is no supratentorial approach, tumor. It means that you can go just for the posterior fossa. From the retrosig, you can get the tumor. And the other but very important thing, the attachment of the tumor is in the posterior fossa between the 7 and 8 and the lower cranial nerve. Here's the vertebral artery. See? And the attachment of the tumor was here. In this case, I extend a little bit the retrosig to expose a little bit more the sigmoid sinus to get more lateral view, but the retrosigmoid approach. When we go to plan the surgical approach for skull-based meningioma, we have to think where the tumor comes, where is the main attachment of the tumor, where the tumor arises. And your approach has to be planned to remove the tumor from the part that's coming. See, in the post-op, very slight facial nerve that is recovered in the end. See, where the tumor come? Tumor come from here. See, when this tumor was small, he was in the petrous bone. You have to plan the approach to that area, not to the area that expand the superior part. Same situation like this. I escaped the video because of the time. You see this, you do the radical safe removal, preserve the function, preserve the facial, preserve the structure, working just in the posterior fossa, same situation. Escape the video. And the pre-op and the post-op. What's the problem in this tumor, in this situation of the retrosigmoid approach? If you want to do a radical removal of meningioma of skull base, you need to remove the tumor, the bone, and the dura. If the attachment is in the tentorium, you need to remove the tentorium. If you do the posterior petrosal approach, your approach is through the tentorium, okay? You use the tentorium approach. You cut the tentorium, you cut the blood supply to the tumor, and you also cut the attachment of the tumor. When you come retrosigmoid approach like this, you can get this pre and post, but this part in the tentorium is more difficult to remove by retrosig. You can, but you cannot do widely that you can do by different approach. If this tumor had one part that was going supratentorial like this, I would do petrosal approach, posterior petrosal approach, as Professor Flawless will show you, and I think today or tomorrow morning. A small petroclival meningioma like this. Why I did retrosigmoid approach? Because of this here. See? This dural tail inside the internal auditory canal. It's very difficult to open the internal auditory canal by petrosal approach, or anterior petrosal approach, or posterior petrosal approach. It's much easier to remove by retrosigmoid approach. And you come like this, el pre and post, and you can clean this and remove this dural tail in this part. There are situations that you can choose at the best way. I can do by retrosig, I can do by petrosal, I call it posterior petrosal. The posterior petrosal, your Y view like this, from the third nerve to the 11 and 12. The retrosigmoid approach is limit view like this. You have a case like this. Why I did in this case petrosal approach? For one thing, the blood supply was all coming from the tentorium. If I do the petrosal approach, no, I train a lot in temporal bone. See, I do my own temporal bone. See? My first temporal bone is December 24, Christmas day in Little Rock in 1993. See, I couldn't find that time any structure in the temporal bone, but I continue training, and temporal bone is the only surgery that totally reproduce the approach that you do in the lab today and tomorrow will be the same that you do in surgery, because it's bone. Temporal is bone, temporal bone. If you drill there, you learn in the lab, you do in surgery. See, if more you train, more you learn, better you do, safer will be your surgery. Why I did petrosal approach? Because the vascularization was coming from the tentorium. I did the petrosal approach, I coagulate the tentorium, and the tumor is gone. The vascularization gone, and the meningioma becomes an epidermoid cyst. No blood surgery. You can get removal. Have situation like this that the people say, oh my God, this part I cannot take it. This cavernosinus. But if you look at this, what's you can see here? This part here. See? Here is the tumor. Here is the tumor. Between them, there is one thing. It's the fifth nerve. It's the fifth nerve. It means that this tumor is not in the cavernosinus. This tumor is in the Meckel's cave. If you do the surgery, see, here's the middle, a left side. Here was the Meckel's cave. I opened the Meckel's cave there. I follow the fifth nerve from the middle fossa to the posterior fossa. Here's the fourth nerve, keeping the arachnoid, see? Don't need to dissect beautifully the fourth. See, I work pre-sigmoid, retrosigmoid, remove the tumor from here, release CSF from her retrosig. Look the fifth nerve from the posterior fossa to the middle fossa. See, here's the fourth nerve. Here's the posterior cerebral, the temporal lobe, the cerebellum, left side, the arachnoid preserved to the basilar artery, the arachnoid preserved to the nerves, and leave that. It's not so clean as you see in aneurysm surgery, but you keep the arachnoid to destruct it. Is the way to save the scene. And what was thinking that was in cavernosinus meningioma was not cavernosinus meningioma, was a macroscope. You could go and remove, and the post-op, the lady will be like this. The Brazilian Japanese, you see the eyes, the preserve, the tumor here's out, the tumor here's out, the tumor here, and the tumor is out. Not mean that, oh, this guy knows, and no, he does cavernosinus meningioma. It's not cavernosinus meningioma. It's Meckel's cave meningioma. It's anatomy. It's understanding the anatomy, is understand the behavior of the tumor, and understand the growth of pattern of the tumor. It's very, very important before to decide any kind of treatment. I'm addicted of microsurgical lab. I did course in more than 15 countries around the world. We do regular our course in Fort Worth, Texas, also in St. Louis with Professor Al-Mefti. We do our course every year in Siberia, that I go every year there, stay 10 to 15 days doing surgery, but go back home to Brazil. The course is the only way to learn skull-based approach. The lab is the only way to learn skull-based approach. But the lab, the 2 days, the 2 or 3 days that you do a course today, does not mean that you leave the lab and go to the OR and go there and do the surgery, and you can do the same way. The course is wonderful to open your mind for new ideas. Open your mind, your soul to go, come back to your university, come back to the medical school, come back to the anatomy department, and go there and train. Here in Brazil, the cadaver and the specimen, the cadaver specimen in Brazil is not so good. You don't have this very nice injection with blue and red that you can see beautiful. You have this cadaver that sometimes is very dark, is smelling bad, but the anatomy is the same. You are there in the anatomy department to learn the anatomy, to help people. We are not there in the anatomy to make nice picture, nice image, to give lectures. You are in the lab now, in the laboratory training, to learn, to understand, to open your mind, to continue a new era, a new way to treat our patient. There is no skull-based surgery. There is no neurosurgery without commitment. Commitment, it means with the patient, with you, with your team. If you work together, see, it's the only way to do the best way. I make a advertisement of our book that's coming out now in August. Supposed to come in May, now it's June, July. I think August is coming, it's ready, it's in press. In this book, you have all the approaches to the skull base with a lot of experts from around the world, step by step, layer by layer, anatomy and surgery, surgery and anatomy. It just tips, I think, the way to learn. And read, dissect, and read again before go to the OR to do surgery and hurt the people. Thank you very much, Professor Naja. Thank you, Professor, for the opportunity. It's a great honor to be. I hope one day we'll go to Morocco to know and to see this beautiful country. Thank you very, very much. And sorry for the long time.
Thank you, Luis. It's just fair because the last time you remember, we give you only 15 minutes. So I
I spoke too much, Oi. So
not too much. It's just, for me, it's not too much. For all the audience, also we enjoy your brilliant and marvelous talk as usual, and give us, of course, all the tips and tricks about the retrosigmoid approach. And we know that it was of the challenging, of course, approach. And we know that today is not neurosurgery is not about the mortality. It's the goal is not only mortality but the morbidity and
morbidity.
Morbidity and the functional, preserve the function as facial hearing now. Sometimes when it's possible, when the tumor is very very small. So thank you so much. My question is, did you use sometimes the endoscopy during the, for example, the schwannoma of the vestibular schwannoma? And I just attended last week and the webinar of the neuroanatomy committee with Professor Majid Sami, and especially with the Professor Schroeder. He shown us a really great instrument about which is in the same time retractor to cerebellum and aspirator and dissector. It's a very, very nice and elegant instrument. I don't know if you have some.
No, I don't
you
have this instrument. Dr. Schroeder is designing this for stores.
And it's very nice and elegant instrument, and I know that it's very interesting to use it with endoscopy.
Yeah, I saw Dr. Professor Schroeder presentation. We were together in Kuwait.
Yes.
Several times. I go to Kuwait very often also to do crazy tumors there. And the endoscopy is very good. In the CP angle for retrosigmoid approach is very good. To see the corners you cannot see. Yeah. That case that I show from the epidermoid, the young lady has facial pain. There was a small tumor in the porus trigeminalis. If I didn't use in that time the endoscope, I will not remove. I will not see. See, and the endoscope show you. See, one issue that's coming today is the exoscope. That Professor Schroeder now is popularizing. He's starting the job. I don't know that would be a great advantage. I don't know if you change your eyes to the patient and took to the monitor, it would be great. I don't know. I'm not familiar with this. For me, Dr. Naja, looks like this. You have a patient in the office, you look at his eyes or her eyes.
Absolutely
or
right.
We are doing the consultation and look the computer. What's your feeling? Yes, you have to do it. Not looking the patient. I prefer to look there by myself, you see? But this corner, this angle is unbelievable. For anastomosis, for STA, MCA, that is plain.
Yeah.
I think the exoscope will be very nice because it's very wide, you can see very nicely. But for deep surgery, that is skull-based surgery, or for aneurysm, that you can, and there is one thing that you don't see with an endoscope. With the microscope, I see my hand enter from here to the dip, okay? In the endoscope, I just see when it's there. See, I don't see the whole trajectory. See, this is one different for me. But I think I don't fight with technology. Technology come, bring everything together. The problem is money. I don't have money to get all the technology.
Yes, it's true. And
Okay.
the exoscope, I use it, I think 2-3 times when we had when we would like to buy the Zeiss Kenevo, and they want to sell us the exoscope with the microscope. So I use it for some time. I totally agree with you. I can't comfortable with it, because it's the philosophy is totally different from the endoscopy. I'm completely agree with you.
Yeah.
If there is any question among the attendants, you know, we have here more than 30. Tu peux le montrer? We will show you all the, and maybe take photography, and we will send it to you.
Okay, great.
There are maybe 30 residents that we will start this afternoon the workshop, and I saw your
facility.
I saw your last slide, and we are of course ready to start with you some workshop like this, even when you want.
Yeah, anytime.
Of course, after this pandemic period. Okay.
I'm ready. I'm ready to go anytime. Okay.
Okay. Thank you so much, Luis.
After the corona.
After the corona. Yes.
Okay.
Okay, Luis. See you soon. Bye-bye. Thank you.
Bye-bye. Ciao.
Thank you so much, Professor Borba. And by this, we reached the end of the first session. So about the video, we'll try to listen to it during the afternoon sessions. So now we move to an important session.